Great to see everyone starting to join us. Wonderful to see such a good turnout for our GIN ANZ webinar series. I'll just give it a minute or two to make sure that everyone can find the link and get their Zoom sorted, run any updates that you might need to do as you do with these things sometimes. We've had a lot of interest in this webinar, so it's very good. Thank you all for coming once again. Let's just check the time. We're right on time, so I can see people are still joining. So we won't get started just yet. I'll just give it another 30 or so seconds. They say it's a little bit like the popcorn in the microwave. It all starts popping at once and then it slowly starts to slow down and the pops don't come as frequent. And that's when you know you're ready to go. And I think we are getting to that stage. So let's begin. Welcome everybody. Thank you for taking time out of your day to join us for our ANZ GIN webinar series. My name is Zachary Munn and I'll be the host for this webinar today. And my co-presenter is Dr. Sue Brennan, who's great to see. And thank you for accepting our invitation to speak today, Sue. And I'll let Sue introduce herself a little bit later on. But thank you once again, everyone, for coming along to this ANZ Guidelines International Network webinar on grade in guidelines. Now, if this is your first time coming to one of our webinars, a special welcome to you. We try to make them as interactive as possible. So to get the most out of this webinar, please do feel free to interact via the chat. Sue and myself will be able to see the chat and what you put in there. And please do introduce yourself in the chat as well. We really love to see or to get to know you all, to know who is actually attending this webinar today, and to learn a little bit about our participants as well. Now, after this webinar, there will be a recording which will be available on the GIN YouTube channel. If you haven't actually accessed the GIN YouTube channel, I can highly recommend it. There's a lot of fantastic resources on that channel from all of the GIN working groups and regional communities, all about guideline development, of course. And we're always trying to improve as well. So if you have any feedback for us, please do contact us at the email address there as well. Or if you have any suggestions for any subsequent webinars. Now, if you're on Twitter as well, please do feel free to tweet throughout the webinar, hashtag ANZ GIN webinar, and then we'll be able to get back to you as well on Twitter after that. And if you are on Twitter, please do follow us at our handle there, GIN_ANZ. We would love to connect with you on Twitter as well, because the Guidelines International Network and ANZ GIN is all about this network of people with an interest in guideline development, in guideline implementation, and evidence-based healthcare more broadly. And we want to connect with like-minded people to keep advancing the field. So please do connect with us. We'd love to see it. Okay, so myself and Sue will be presenting today all about grade for systematic reviews and guidelines. Now, it's a very hard task to present grade in just this short time, so we'll just be giving you the highlights today. But of course, if you have any questions after, please do contact myself or Sue. Now, I would like to mention that I am based in Adelaide, South Australia. I work at the University of Adelaide, and I'm on the traditional lands of the Kaurna people. And I'd like to pay respect to the Kaurna elders past, present, and emerging. And I'd also like to acknowledge any Aboriginal or Torres Strait Islander people attending this webinar today. And we acknowledge that the land we're on always was and always will be Aboriginal land. Now, of course, always need to go through interests and disclosures. So this, by means of introduction and to get to know me and my disclosures, I'm the Director of Health Evidence Synthesis, Recommendations and Impact at the School of Public Health at the University of Adelaide. I'm also the Director of a JBI Adelaide Grade Centre and a member of a grade working group. I am the current chair of a Guidelines International Network, and I've received funding for lots of different systematic review and guideline development projects. But importantly, all of this funding goes to my institution and doesn't go to any personal funds. I'm also funded by an NHMRC investigator grant. And just for the slides that I'm going to share, I'd just like to acknowledge that some of the infographics particularly are coming from other members of the GRADE working group, and particularly Professor Holger Schoenemann and Dr. Carlos Coelho for some of these slides. Okay, so what are we going to discuss today? Well, I'm going to talk a little bit about the GRADE working group and a background and introduction to GRADE. And then discuss the state of GRADE in Australia as well. And then a very quick introduction to how we can establish certainty in the evidence using the GRADE approach. Then I'm going to hand over to Sue, who's going to take us through GRADE for guidelines and how we can move from our evidence and our results and systematic reviews to actually making decisions and recommendations in guidelines. Then hopefully towards the end of this 1 hour session, we'll have some time for some questions and discussions, and we may even be able to have some debates as well. And this is a meeting format for Zoom, so you might even be able to unmute yourself and ask some questions live, which would be fantastic. Now, I'm just looking at a chat and no one has introduced themselves yet. So someone please do get the ball rolling. Please do introduce yourself in the chat. Tell us who you are, where you're joining us from, and what you do. It would be lovely to hear a little bit about you all. So let's get started. First off, I thought it might be nice to just get a little bit of a gauge about how much all of you know about GRADE. And some of the examples or options we're going to ask, well, have you prepared a guideline using GRADE methods? Have you read published papers on GRADE methods? Have you prepared a systematic review or a GRADE summary of findings table? Have you attended a GRADE meeting, workshop, or talk previously? Or perhaps you don't know anything about GRADE. Perhaps this is your first introduction, and if so, a very special welcome to you. And of course, we're going to be really covering the basics today about GRADE. So I'm going to launch that poll now, and hopefully you can see that. And of course, in the chat, if you want to introduce yourself, I can see people are starting to introduce themselves, which is fantastic. But if there's anything else you'd like to know more about in terms of GRADE and how to use GRADE in systematic reviews and guideline development, please do put that in the chat as well. And if we don't get time to talk about it in our presentations, we might be able to talk about it during the discussion and questions at the end of this session, or offline as well. So fantastic to see lots of responses coming in on that poll there. Very good, quite evenly spread across the board, which is good, which is interesting. And I can see in the chat that we've got a few people from Australia and New Zealand, but we also have some international guests coming along here today. So that's fantastic to see. Welcome, of course, to you all. All right, it looks like most people have participated in that poll. So I'll share those results. So if you can see these results, it looks like there are some people who have prepared a guideline using GRADE. Many people have read published papers on GRADE or attended a GRADE meeting, workshop, or talk. And then there's a very good percentage of people who actually don't know anything about GRADE just yet. So you're in the right place. Hopefully this is a nice introduction to using GRADE in systematic reviews and guidelines. Thank you everyone for entering those responses into the poll. Okay, wonderful. So let's keep moving on then. So starting off, let's start off with an introduction to the GRADE working group. And I think it's important to probably start off with the big question, why GRADE? And when we ask this question, sometimes it's useful to actually go back in time a little bit before GRADE became the gold standard in systematic reviews and guideline development, and to think about what we used to use, which were our levels of evidence and our grades of recommendation systems. And these levels of evidence were largely tied to study designs. And at the top of the levels of evidence or evidence hierarchy or evidence pyramid, you'd have your systematic review or meta-analysis of randomized controlled trials, followed by randomized controlled trials, followed by perhaps quasi-experimental studies or observational studies, cohort studies, case controls, etc., etc., etc. Now, there are a lot of problems with these very useful, but perhaps overly simple levels of evidence and evidence hierarchies, because they didn't take into account other things that are really important, which could impact the quality of evidence or our certainty in the results of research, such as things like imprecision, such as things like risk of bias, such as things like applicability or indirectness as well. Now, lots of different groups realize this. So different guideline groups, different professional societies, different governmental bodies, etc., started to create new levels of evidence and grades of recommendation. And you can see here they started to discuss things other than study design, such as homogeneous RCTs with good methodological quality. So RCTs are finding similar results, so they're homogeneous and good methodological quality or low risk of bias. And yet another group created their own levels of evidence and grades of recommendation system. And then another group did as well, and so on until it got to a point where we literally had dozens and dozens and dozens of these different levels of evidence and grades of recommendation systems, which made it very hard for end users to recall and know, well, when they're looking at the research evidence and thinking about implementing a recommendation, it made it difficult to understand, well, with what strength should we be following this recommendation, or how certain are we of this evidence? And it all got incredibly confusing. So after many, many years of increasing confusion, the grade working group was established with a goal of developing a unifying, transparent and sensible system for grading the certainty of evidence and making decisions. And nowadays in 2023, grade has really become the gold standard in systematic reviews and guideline development. And you can see that hundreds of organisations nowadays use and endorse the use of grade and systematic reviews, guideline development and health technology assessment, such as WHO, NICE, the CDC, ARC, JBI, Cochrane, etc., and many, many others. Grade can be used for systematic reviews, health technology assessment and guidelines. And the grade working group itself is a very international and diverse working group with greater than 600 members, probably even more than this now. And we run regular workshops at conferences alongside GIN, Cochrane, WHO, JBI, etc. And it's a very open and multidisciplinary group. If you're looking for some of the key guidance and papers about grade, there's a really nice introductory series in the British Medical Journal in 2004 and 2008. But for ongoing developments in grade, because grade isn't a static methodology, it's always advancing, please check out the Journal of Clinical Epidemiology, where official grade guidance papers are published. I think we're up to about 34 or 35 now. For official grade guidance papers in the Journal of Clinical Epidemiology. So if you're looking for grade guidance, you can look at this journal. There is also a grade handbook which you can access, which provides the basics of grade. And there's some IT applications such as Grade Pro GDT, and also Magic can be used for grade as well. Now, across the globe, there are many different grade networks and centres. And you can see here, there are grade centres or networks across these various countries. And I'm really pleased to say there are two grade centres here in Australia, one here in Adelaide, and of course, one in Melbourne, which Sue is the director of. So that's why grade and who grade are. Let's turn to now grade in Australia. So as I've mentioned, in Australia, if you're doing a systematic review, big organisations like JBI and Cochrane endorse and recommend the use of grade and really require grade in their systematic reviews. And the same goes for guideline developers. So if you are doing a guideline and you want NHMRC approval of that guideline, then you actually now need to use grade. And this has been the case for a few years, but really just want to make this very clear that if you are doing a guideline in Australia nowadays, NHMRC will only consider and approve guideline recommendations which have been developed using the grade framework. And this neatly aligns to actually the 2016 NHMRC standards for guidelines. And if you go through all of their standards, but particularly standard 6, you'll see that evidence-informed guidelines really should be informed by well-conducted systematic reviews and consider the body of evidence for each outcome, including the quality of that evidence. And this is where grade obviously comes in. And just a shout out, I think, to the NHMRC Guidelines for Guidelines manual or handbook, which really provides incredibly useful information if you are going to be developing a guideline. Even if you're not in Australia, if you're just developing a guideline, this is a really wonderful resource with a lot of good guidance about how you should develop your guideline as well. So please do check that out. Now, a few years ago, my colleague Tim Barker led a study which looked at whether or not people in Australia, guideline developers in Australia, were actually using grade. This was a few years ago now, but it actually, there was quite a few issues with using grade. A lot of guidelines simply didn't use grade. And then those who did say they used it didn't really apply it correctly. I'd like to think the case, this is no longer the case. We only searched from 2011 to 2018 in this work. But just goes to show there is always room for training and improvement. And that is one area where our 2 grade centres here in Australia can actually help, here in Adelaide and in our Melbourne centre as well. And things that we do at our grade centres is we have a newsletter which can help you keep up to date with developments in grade and training opportunities, etc. We also run workshops in grade as well. So if you enjoy the introduction that you hear today, but you want some more information, please do contact myself or Sue, or go to our centre websites to look at upcoming training opportunities. And we also sometimes run events as well, which is always a lot of fun. So that's grade in Australia. And now I'm going to quickly run through the actual grade approach for assessing certainty of the evidence. So first off, if you're coming from a guideline development perspective, when we make a recommendation with grade, we need to consider all of these things. We need to consider the balance between benefits, harms, and burdens. We need to consider patient or participant or whoever's going to be impacted by the recommendation, their values and preferences. And we need to consider whether recommendations will reduce inequities across a population or potentially increase inequity. We also need to consider resource use, feasibility and acceptability. And alongside all of this, we need to consider our certainty of the evidence. And so the big question is, well, how do we determine our certainty of the evidence? And alongside that, what do we mean when we say evidence? What actually is the evidence? So let me run through a little example here. So here's a systematic review that myself and some colleagues did some years ago now. This was looking at rinse-free hand wash, so basically hand sanitizer, for reducing absenteeism among preschool and school children. This was published in early 2020 in the Cochrane database of systematic reviews. It was a very, very interesting time actually to have just published this review. Now, for one of our outcomes, we were looking at absenteeism one of our outcomes was absenteeism due to any illness, and the intervention was rinse-free hand wash versus control. And so our evidence, so to speak, is this final result here, this incident rate ratio of 0.82. So when we're saying what is the evidence in this case was an incident rate ratio of 0.82. which really corresponded to without hand sanitizer, you could expect children to be sick 16 days per 1,000 days. Whereas in the sanitizer group, there'd be 13 sick days per 1,000. So a small reduction in days absent due to illness. But the question is, this final result, this incident rate ratio of 0.82, how certain are we that this is actually reflective of the truth? What is our confidence in this actual finding? And that, of course, is where grade comes in. Now, the first thing to know about grade is that grade is outcome centric. So you might remember from those levels of evidence that I showed you earlier, they were all study specific rating systems where you would say, if you have an RCT, all of the data, all of the results from that RCT could be considered level 1 evidence. If you had a cohort study, maybe all of the results, all of the findings from that study could be considered level 3 evidence. But whereas grade, just like we do in systematic reviews, looks at outcomes across the individual studies, and then provides a rating of a certainty for the pooled estimate, or for all of the data contributing to that particular outcome. So we don't do a study-specific rating, we're actually doing a rating of the pooled outcome, or the outcomes across the studies. Okay, so once again, this is the result, this is the evidence, or what we might call the estimate of the effect, which we want to rate our certainty in. So what are the determinants of certainty in a body of evidence or a finding according to grade? Well, if we have a body of evidence from randomized controlled trials, then that starts off as high. We have high certainty evidence. And then there are 5 factors that can lower our certainty. The first is risk of bias criteria. And if there are any issues, or if there is a high risk of bias in the studies contributing data to that outcome, then that can lower our certainty. Now, if we have observational studies, if we don't have randomized controlled trials, these observational studies, because of its lack of randomization, will start off as low. And I'll discuss this a little bit more soon. Now, if there's inconsistency across our study results for an outcome, so if we're finding that results from the studies are scattered all over the place, and we can't explain this inconsistency, this can also lower our certainty. If the actual study populations, or the trials or studies themselves aren't relevant, applicable, generalizable, or transferable to our populations that we're planning to make recommendations for, or that we're planning to apply the findings to, this is a form of indirectness, and this can lower our certainty in the results as well. And then imprecision. So if we have wide confidence intervals, particularly if they're crossing important decision-making thresholds, this can also lower our certainty. And the final thing that can lower our certainty in a body of evidence is if there is publication bias, or if we suspect there may be publication bias, so that we may detect that we haven't actually included all of the evidence that exists on that particular question or PICO. Now, there are also 3 factors that can increase our certainty, and these normally apply to observational studies or non-randomized studies. So a large magnitude of effect, so a large, consistent and precise magnitude of effect or result can increase our certainty. If there is opposing plausible residual bias or confounding working against an effect, but perhaps we're still seeing that effect anyway, this can also increase our certainty. And if there is a clear dose-response gradient as well. And if you remember, this is one of the Bradford Hill viewpoints for causal relationships. And if there is a clear dose-response gradient, we can be more confident or more certain that it's actually a true effect. So how does this look in practice? Well, what we do is we may have different bodies of evidence in our systematic review. So we might have some outcomes where we have data from randomized studies, some outcomes where you have data from non-randomized studies. As I've mentioned earlier, randomized studies starts off as high. This is our initial certainty of evidence. And then we consider these 5 domains which can downgrade the certainty of evidence. We consider 3 domains which can upgrade the certainty of evidence, and we end up with a rating of high, moderate, low, or very low. And this reflects our final certainty in the actual results. Now, some of you may have started to use Robin's I, which is the risk of bias in non-randomized studies of interventions. And when we use Robin's I to appraise non-randomized studies,
Robin's I
grade a little bit differently, in that our body of evidence from non-randomized studies also starts off as high. This is because when we use Robin's I, basically we're comparing the results of this non-randomized study that we're looking at to a target or hypothetical trial or ideal trial if that was feasible and ethical and possible to actually do. So we're benchmarking it basically against the ideal randomized controlled trial for that PICO. So in that case, we can actually start off as high, but in practice, what happens is that when you do assess these bodies of evidence using Robbins I, in the vast majority of cases, I'm really yet to see one where this hasn't been the case. We actually need to downgrade for risk of bias concerns because we would have extremely serious concerns due to the lack of randomization. So although it starts off as high, it will very likely our body of evidence, our certainty in the body of evidence will still end up with the same grade certainty of evidence. Okay, so coming back to my example, when we talked about what is the evidence, and we had this incident rate ratio of 0.82. Well, after applying the grade factors, in this case, we actually ended up with very low certainty of the evidence. And a really important principle in grade is that we actually need to be very transparent and justify our ratings or our decisions to downgrade or upgrade our certainty in the evidence. And you can see here, we made the decisions to downgrade due to risk of bias issues, due to heterogeneity issues, and also imprecision. So we ended up with very low certainty evidence in this final result. And an analogy that we sometimes like to use when we discuss grade and what we're trying to do with grade is we can compare this to two meteorologists working in the Bureau of Meteorology, where one meteorologist says to the other meteorologist, I figure there's a 40% chance of showers and a 10% chance we know what we're talking about. And this is very similar to what we do. So they're communicating the result or the magnitude of effect or the estimate of the effect. This is a 40% chance of showers. But also, they're also communicating their certainty, quality, or confidence in the evidence. And that is what we use grade for. So this has been a very whirlwind introduction to grade. Hopefully it's been helpful. Like I've mentioned, if you have any questions, you can put them into the chat. And you can also contact us later as well. But it's now my pleasure to hand over to Sue, who is going to take us through trustworthy recommendations using grade and moving from evidence to decisions. So I'll stop sharing and hand over to Sue.
Thanks, Zach. Hopefully my slides will load in a second. Looks like they're there. All right, thanks very much, Zach, and thanks to yourself, Daniela and Kelvin, for inviting me to present today. I'm going to pick up where Zach left off, really thinking about how we go from the evidence to recommendations using the grade evidence to decision process. And like Zach, we owe much to the larger grade working group in terms of content. It's always evolving, always developing, and it's interesting to watch each other's presentations because we inevitably say some familiar things that we've inherited from many of the greats in the grade working group. Okay, I'd like to begin by acknowledging the traditional owners on the lands in which I live and work, the Gunnakurno people. So we're sitting in the eastern part of Victoria, the area spanning from Wilson's Promontory through to nearly the New South Wales border, a beautiful part of the country. I'd like to pay my respects to the elders past, present and emerging, and including any First Nations people who are joining us on the call today. Like Zach, I have a few declarations. We both have a vested interest in grade. I'm the director of the Melbourne Grade Centre and I am an elected member of the executive for the Grade Working Group. I'm employed at Cochrane Australia, which is based at Monash University, and funding for my salary is derived entirely from the NHMRC through either funding that's provided to Cochrane Australia to support the production of systematic reviews in Australia, contributed to methods guidance and methods research, and also through the Health Evidence and Methods panel, where we do systematic reviews and provide methodological guidance to the NHMRC. So what I'm going to start with is really just, again, a little bit of a brief intro into where grade sits in the guideline development process. So very much dovetailing with what Zach's already talked about, and I will just mention again the ANZ and MRC standards and where grade fits. Then the bulk of what I'll talk about is around using grade methods to go from evidence to recommendations. And I've tried to keep a really practical focus on this and think about the process rather than the detailed kind of theoretical basis that might sit behind it. Three kind of steps in that I think are particularly important. And the first is thinking about how we reach agreement on the interpretation of findings. So really taking that evidence that Zach talked about and agreeing with members on the panels about how we interpret that. Using the evidence to decision framework to go from the evidence to make a recommendation, and using the grade evidence to decision framework to decide on the direction and strength of recommendations. So 3 main steps in that process of going from evidence to recommendation. So where does grade fit in the guideline development process in ANZ and MRC standards? If we look at this really kind of simple, and any of you who have done guidelines will know how simple this is, simplified schematic of the guideline development process. It begins obviously with establishing a guideline development group. In the middle is that big chunk of sometimes quite difficult and time-consuming work to do the systematic reviews or bring together evidence to inform the guideline recommendation. And that final step of making recommendations, which is a very judgment-based process. Grade fits into those 2 end stages, and Zach has talked very much about the first of those 2. I'm talking about the second. It provides a structured system for both of these steps. It also provides a common language, and I think it's important that we recognise that over years, in considering all those different systems that Zach talked about, for end users, that's a very confusing space to be in. So this common language ensures that if we talk about high certainty evidence, we talk about a conditional recommendation, that an end user knows what we mean without having to delve into a whole chapter on the methods we've used in the guideline. It also provides an explicit basis for reporting recommendations, and you've already seen some of that in terms of the summary of findings tables that Zach showed, and I'll show you some further examples. So just to recap what Zach said, really grade methods allow us to meet standard 6 and standard 7 of the ANZ and MRC standards for guidelines. And standard 6 obviously is around considering the body of evidence for each outcome. That evidence goes beyond the benefits and harms of an intervention to thinking about the whole range of factors we need to consider when we make a recommendation. Grade also allows us to clearly link each recommendation to the evidence that supports it, and provides a mechanism for grading the strength of each recommendation. And in grade, we talk in terms of strong and conditional recommendations, and those recommendations are either for or against a particular intervention option. So thinking about that first step in moving from the evidence to a decision, we always encourage our guideline panels to agree on the interpretation of findings. Often this is a process that makes some panel members a little bit less comfortable than others, depending on where they're coming from. So those with a strong research background or a lot of experience looking at these summary of findings tables find it quite an easy process. Others will be quite unfamiliar. So we try to get to a common point with that before we start down the process of making a recommendation. So really using that information that Zach's just talked about that's derived from the systematic review, that information where we assess the certainty of evidence and we provide an interpretation of each of the results from that evidence. This is another format similar to what Zach showed, but from the Magic App platform of a summary of findings table. It's a concise summary of the evidence that we have. It presents results for each outcome in turn and gives information about the direction and size of the effect and how certain we are in each of those results. So what we would do at the start of a panel meeting is generally ask the panel to discuss and agree on the effect on each of our clinical outcomes. We don't shy away from that. We want panel members to agree on whether we're seeing benefit and harm and whether that benefit or harm is important or not. And when I talk about important, I mean of importance to patients. Okay, grade facilitates that discussion by providing a plain language interpretation of each result. So in our meeting, we will consider this plain language interpretation, which includes information about the size of the effect and also how confident we are that this is the true effect. So if we were to take one result in the context of a meeting, we would generally have someone from the technical team facilitate the meeting. They would go through each of these outcomes in turn, describe the results to people on the panel, and check that everyone on the panel agreed with this plain language interpretation. So basically we're seeing an increase in the number of people who report treatment excess. Does the panel agree on this or not? And we would have some discussion around any disagreements, and consumer input would be particularly important at this point in the process. So once we've reached agreement on the interpretation of each of those outcomes, we need to move from evidence to a recommendation. So how do we actually go from this evidence to a recommendation? By which I mean an actionable statement of what to do. So it's not a statement of the evidence, it's really a statement of what to do in clinical practice. This is where the evidence to decision process comes in. It enables us to go from evidence to recommendation. So in the process of making a recommendation, there are many different factors we need to consider. We've talked about those individual results for each outcome from looking at different benefits and harms. At this stage, we're going to have to move up the next level and think across the outcomes and balance the benefits and harms. We'll also think about those other factors that Zach mentioned. So how much people value each of the main outcomes of an intervention, and a range of implementation factors such as feasibility, acceptability, equity issues, and resources. And all of those will feed into our recommendation. And the grade evidence to decision framework basically takes account of all of these factors and provides advice on how to consider them in the guideline process. So by this point, we're sitting down at that end step of making a recommendation, using the grade evidence to decision framework to consider each factor systematically, to record supporting evidence and judgments for each factors, which underpins that principle of transparency that's so important in guidelines, and to make a recommendation. There are 12 different factors in the evidence to decision framework that we consider. We consider each of them in turn and make a recommendation. Now, this is the full implementation of the framework that you'll see if you use Grade Pro software, for example, and that is discussed in those 2 grade papers that I've put up in a previous slide. In Magic App, there are slightly streamlined versions that some panels use. Thinking about a process that we typically use in the panels that I've been involved in, we step people through the process, and I think it's worth sort of talking about the practicalities of that. So we would consider the evidence for each of those factors in turn. So we'd start by perhaps thinking about desirable effects or equity. Thinking about equity, we would review the evidence in relation to equity. We would ask the panel to vote. What do they think the likely impact on equity would be of making a particular recommendation? Would equity be reduced? Would it probably be reduced, and so forth? So we're very much involving the panel in a structured process of making decisions. One of the benefits of voting or polling early in that process is that it helps us identify if we've got disagreement on our panel, if we've got divergent views. And that provides a very efficient mechanism of facilitating discussion of those different views or opposing views, which we find is a very effective way really of identifying where perhaps there's a lack of consensus. Through that discussion, we don't have to achieve consensus. It's not a requirement in grade to have consensus. We do have to make decisions. And if we don't have consensus, we need in that framework to reflect where the points of disagreement are. Really important, because that probably reflects the wider community's view on some of the decisions that will be made in the panel. After we've gone through each of those factors in turn, we weigh up those factors and have to make a decision as to whether overall the evidence favours the intervention, favours the alternative, or whether there's a close balance. From that will come our recommendation, and generally once we've made those decisions, the recommendation basically falls out of that in terms of whether we're recommending for or against an intervention option and whether or not the recommendation is conditional or strong. Then comes what I think is probably one of the most difficult parts of the process, and we generally don't do this in the meeting, and that's the process of crafting the wording of the recommendation and all the underpinning practical advice that might go with that to help those implementing the guideline. Okay, so just to have a couple of very quick slides to think about an example. So this is an example from a living guideline that I've had some involvement in terms of facilitating the guideline. No involvement in the grunt work behind it or the conceptualisation of the guideline. It's a very talented team from ANZ that have done that. This is a particular recommendation from that living guideline looking at opioids for the treatment of pain in adults with rheumatoid arthritis. And here they're making a decision around whether for people with persistent pain who've received optimised therapy, whether or not they should have recommended opioids or continue without opioids. Now here they use the streamlined version of the framework that's in Magicat. They considered 7 different factors. I want to highlight 2 of those just to illustrate the process. So thinking about the balance of benefits and harms, what's important here is to think about what's different from what we've talked about already. So again, this is underpinned by that evidence from the evidence profile. We really are now going to focus very much on the plain language interpretation because we've agreed on all the effects on those different outcomes. So the questions for the panel are really, are the beneficial effects large enough to recommend this treatment? What about the harms? Are they too big to risk having the treatment? And we need to make a summary judgment across all outcomes. Overall, the process we're trying to follow is to get us to a point where we can say, should we recommend for the option, against the option, or is there a very close balance? That's going to mean we've got some difficulties, some challenges that really needs to bring in all those other kind of factors that we discussed in order to form a recommendation. As I said, at this point, we're moving away from our summary table. We've agreed on those plain language interpretations. We would use those to anchor our decision making at this point, getting away from the numbers, just helping people interpret the simplest information possible. And I would pose the question to the panel, what do you think? Do you expect that we're going to see small net benefit from this recommendation, substantial benefit, or important harm? And that will give us some information about the direction of our recommendation. Even if we don't have evidence, we need to record the panel's judgment and the basis for those judgments. It's a common misconception that if we don't have evidence, we can't make a recommendation, or we can only make what's called a consensus recommendation. In grade, we conceive of every recommendation as being a consensus recommendation because we work through a consensus process to form those recommendations. The difference is some are underpinned by systematic reviews and other times we'll have statements that are not underpinned by systematic reviews. That's the main difference in the process we see, not so much the use of consensus. So just looking at another factor for a little bit of contrast, if we think about acceptability as one of the important factors to consider when we're implementing an intervention, here we start to think about stakeholder views on whether the intervention option that we're proposing will be acceptable to all, to health professionals, policymakers, consumers, and anyone else with a stake in this decision. Again, we would present the panel with evidence. We may have evidence from reviews, from qualitative studies, a whole range of sources. We may just have some questions to pose to the panel. And again, what we would do is ask them what they think. We would review the evidence and ask them whether or not they think in terms of acceptability that most would consider the option we're posing acceptable, most would consider it unacceptable, or whether there would be a close balance between the two. Possibly variability in the kind of views on acceptability of the option. So then we're faced with a situation where we've gone through each of the factors. I've illustrated only 2 of them. We've gone through each of those factors and we need now to decide on the direction and strength of our recommendation. This involves balancing all factors. So we need to think across all of the factors, all of the judgments we've made, all of the evidence that's been considered, and determine whether or not we're going to make a recommendation for or against the intervention option relative to the alternative that we've been considering. Thinking about that opioids example that I've been working through, you can see we've got a sea of yellow here. So aside from feasibility, where it was considered that recommending opioids, there would be no issues with feasibility because of low cost and availability. For all other factors, the panel felt like the judgment was very borderline. And in fact, through the panel discussion, we had some really heavy debate around the balance of benefits and harms. And that difference of viewpoint was well reflected in the evidence to decision framework, so that someone coming along could understand exactly what went on in the panel's deliberations. Similarly, we had some very compelling views on the balance of benefits and harms from patients on the panel. It was really instrumental in turning around some of the decisions the panel would have made otherwise. And finally, there were a lot of views that there was variable views on the acceptability of these interventions. And they're just some examples that I've pulled out to kind of illustrate what might go on in any particular panel process. So as I said, in a grade recommendation, we have to make a decision about a direction of effect, so for or against a particular option under consideration, and the strength of our recommendation, whether we're going to make a strong or a conditional recommendation. We have some meaning attributed to strong and conditional recommendations. So in terms of implementation, a strong recommendation really means that almost all patients would want the recommended option and clinicians should do it. We don't necessarily have to have a shared decision-making process in such circumstances because there's such compelling evidence that this is the most effective thing to do. A conditional recommendation, in contrast, and we make many more conditional recommendations in grade than strong recommendations, is a situation where most patients would want the recommended option, but not all, and clinicians and patients will need to consider the options. Sometimes this means there's a much closer balance between benefits and harms. Other times it means our evidence isn't so certain, but it may simply mean that it's a really critical question where patients vary in their views on the relative benefits and harms and would make different choices, and therefore a shared decision-making process is absolutely instrumental. There are a range of situations in which we make conditional recommendations. As I said, sometimes we have a close balance between benefits and harms. Sometimes we have low or very low certainty evidence. Really critical is whether or not patient preferences vary importantly. And there may be other issues of importance, such as, extreme costs, for example, with one option compared to the other. Thinking again about that opioid example, they came up with a conditional recommendation, and there's a very clear statement of what the action should be. Do not routinely use opioids for the treatment of pain in rheumatoid arthritis. But you can see that there's a condition where you might do the alternative. So a brief course of short-acting opioids may be considered for severe pain when analgesic options have failed. So not at all precluding the opposite course of action, but being very clear the circumstances in which you would implement that. Alongside that is a detailed rationale for why the panel made the decision they made, and practical information to help those using the guideline actually implement that recommendation. So in conclusion, the grade evidence to decision framework aims to help guideline developers consider all relevant factors in their decision making and to record supporting evidence and judgments for each factor and the rationale for those judgments. As such, the framework really provides a systematic and transparent approach for making recommendations. Okay, I think I'm going to hand over to Zach now, who's going to lead question time. So thank you very much.
Thank you, Sue. That was a wonderful presentation and covered so much of the important points in such a short time span. So well done. Not easy to do. And I can see there's some really nice feedback coming in the chat as well. So that's absolutely wonderful. So we do have some time for some questions. We've got about 10 or so minutes, and you can put your questions into the chat. There is also an official Q&A where you can put some questions in as well. And if you'd like to, I'd encourage you as well. You can raise your hand using the Zoom functionality to raise your hand. And you can ask a question live as well. So we get to hear your voice, which would be lovely. So a few different options there for people to ask questions as well. So there was one question just whilst we were waiting for everyone, which I did answer in a Q&A, but there was a question about Magic App compared to Grade Pro for guideline development. And I wondered if you had any thoughts about the pros and cons of each.
I think, Zach, as you know, we both, through the grade working group, learn an awful lot about Grade Pro. I really love it for doing systematic reviews, and I really like the full implementation of the grade evidence to decision framework. I think the stepping through of judgments in Grade Pro, from my perspective, is much easier to work with than MagicApp. However, MagicApp is a fantastic platform for publishing guidelines. It's a fantastic platform for underpinning living guidelines. And I do find that some panels prefer the simplified kind of decision-making process that has been implemented in MagicApp. That said, we tend to always run polls in guideline panels, because I think whether we use MagicApp or Grade Pro, panels still take a bit of time to figure out what questions we're asking of them when we make each of those judgments. It's a learning process for all of us. And I think every time I do a panel, I don't know about you, Zach, but I learn something new, and sometimes get, there's left field things that I hadn't thought of before. So, I think there's pros and cons of each.
Thank you, Sue. Very clear. We've had a question from Kay. She's asked, is there a recommended risk of bias or quality assessment tool to use for RCTs and observational studies to assist with a grade process? I know there are many, so any recommendations for consistency? Did you want to have a go at this, Sue?
Well, I'll probably give a bit of a biased answer here, which is, Cochrane Risk of Bias tool and Robin's Eye. But I think there are some personal preferences that people have. What I would say from a guideline perspective is the more we harmonise the approaches we take in systematic reviews, the easier we make it for other people to use our reviews and to update and reuse recommendations or adapt recommendations for others. So I think from that perspective, it is ideal if we can use a commonly used tool. So one of the Cochrane tools, obviously, in the risk of bias tools, are commonly used. And I guess there are some other examples that we can include when we talk about observational studies. So you might want to speak to that, Zach.
Oh, no, I agree completely. If we all start using the same methodology, we make it so much easier to reuse each other's work, to share work, and to reduce duplication of effort and research waste. So I think I agree completely. In saying that, grade, I think this is still true, grade is agnostic to the risk of bias or quality assessment tool which is actually used. So you can use different tools, and particularly I think for observational studies, some people prefer to use different tools than, say, Robin's Eye. But I would encourage people, for consistency purposes, to look at using the Cochrane Risk of Bias 2.0 tool for RCTs, Robin's Eye for non-randomized studies of interventions, and then the other tools for other question types like QuadUS for diagnostic test accuracy, QUIPS for prognostic factors, ProBus for prognostic models, etc., etc. The more common, widespread tools, I think it's very useful if we all start singing from the same hymn sheet. And even though once again grade is, I think, officially agnostic to tools, I think you'll see there's a lot of crossover between the grade working group and leadership and Cochrane and development of these tools, and there's really clear guidance, I think, from grade about using Robin's Eye and the Cochrane tools as well. So I think that makes the most sense. Well, very good. So we've only really just touched on grade for systematic reviews and guidelines, and I think we've focused largely on grade for questions about interventions. Would you mind mentioning where else grade could be useful?
Thanks, Zach. That's probably more your arena than mine, to be perfectly honest, but very obvious ones around thinking about questions relating to diagnosis. So diagnostic test accuracy is a very big area of development in grade, and obviously an area that's developed rapidly over the last 10 years in terms of systematic review methodology. An area that I know Zach has an interest in, which is in prognostics, and also looking at prevalence. We can use grade there. We can use grade methods for qualitative questions. So thinking about all those different factors in the evidence to decision framework, for example, there are many of those kinds of questions that might be well informed by systematic reviews or evidence that is qualitative. So grade has methods for SUQUAL is the methodology we use, that's used to assess qualitative evidence, our confidence in results from a qualitative evidence synthesis, for example. There are probably many others. We can do the same for patient values and outcomes. We can look at health economic evidence. Really, most of the types of evidence we might want to look at, we can cover. I'm not sure, Zach, do you want to add to that?
No, I think that's right. Pretty much any type of question that arises in clinical practice or public health, or even preclinical sciences now as well, and environmental sciences, etc. GRADE have developed or are developing methodologies for pretty much. So it's a very broad methodology, obviously. Very good. We did have another question. This is from Kathy. She is asking, would it be desirable for researchers to have a good understanding of GRADE processes and consider these in the design of their research studies? What do you think, Sue?
This is the beauty of being the chair, Zach, isn't it? You can throw the questions to me. Look, I think there's a particularly interesting question around risk of bias, because I think if we understand risk of bias, we can do two things. One of the things that as systematic reviewers we want to do is we want to provide a fair assessment of every study we include in our reviews. The better that researchers doing primary research do in terms of understanding what information we're looking for, how to report that information, the more likely we are able to be in terms of being fair in assessing the potential risk of bias in your study. I think there is also some really nice work actually led by a researcher called Isabelle Boutron, who's based in France. They did a really nice study looking at the risk of bias in randomized trials, and what of those biases were actually preventable if you designed your study slightly differently without major ramifications for the resources or feasibility of the trial. And there was a whole range of things that people could actually do that would actually minimise the risk of bias in their trial just through simple changes or comparatively simple changes in the design of those studies. So I think in terms of where we can make a big difference, we can certainly make a big difference by understanding where biases come into primary studies. Some of the other things like indirectness is a little bit more difficult, because I think most people set out to answer a question that's an important and relevant question to them. It's not always a perfect match with the questions that a guideline developer will be asking. So that's a little bit harder. In precision, of course, every panel that comes to fund your grant will be looking to make sure that you've got an adequate sample size. But to some extent, we're trying to address that in reviews by bringing together the body of evidence and capitalising on all studies irrespective of their size. And I think that's probably and publication bias would be the other one. Please make sure you publish all your results, whether they're interesting or not. That is probably the really big one, because we know that missing results from studies is a really concerning problem for us in reviews and guidelines.
Great response. I have nothing to add to that. That was absolutely perfect. Thank you, Sue. And last question for today comes from Yasser, who is actually the chair of the GIN adaptation working group, I believe. So thank you for coming along, Yasser. He's asked in the chat, would you recommend sharing systematic review summary findings tables and guidelines, evidence decision tables from published guidelines as part of the rising open science movement free of charge? And if yes, which organisations do so, especially considering cross-country graded development initiatives? I'll have a crack at this, Sue, and then you jump in. And Yasser, you jump in too, because I know you know a lot about this. So graded development is basically it's a process to adopt or adapt or develop de novo guidelines using the GRADE approach. And as more and more people come on board and use GRADE, it's getting a little bit easier, I think, to take the work of other guideline groups, particularly their evidence review work and some of their evidence decision tables, and then to contextualize it to your jurisdiction or the populations that you'll be making recommendations for. So this is fantastic. It's reducing costs, it's sharing work, it's increasing collaboration, et cetera, et cetera. So it's absolutely wonderful. So I think it's fantastic. I think ideally we would be doing that. Ideally most people are, and but what we need to do this is a culture of sharing, and there perhaps for very good reasons, some groups who do not feel like it is appropriate to share all of the pinning data for their either systematic reviews or guidelines, perhaps because of funding issues or other types of issues as well. But from my point of view, I think this is absolutely fantastic that we're starting to see groups do this sort of collaboration. And I know Hugh Maguire's here from NICE, and I believe there was a lot of collaboration between NICE and the COVID task force here in Australia. I think that was a good example. Sue, did you have anything to add to that?
No, except to say, Zach, I think it's one of the points I overlooked in talking about Magicat versus Grade Pro. I think Grade Pro offers the opportunity for people to publish their evidence to decision frameworks and summary findings tables, irrespective of whether it's embedded in a larger guideline or not. And so probably is a really useful platform for that. And I completely concur with everything you've said there, Zach, in terms of the benefit we all reap from sharing recommendations and the evidence underpinning those.
Wonderful. And I know we're at time, but Yasser, do you want to just give a little point on that and maybe a plug for sharing guidelines around the globe?
Yes, actually, this comes from two backgrounds, because also I'm part of the guideline collaboration working group. So we are working on some like sort of principles or a toolkit for this. But I mean, because we have faced a lot of challenges and barriers, especially for non-funding projects, especially for low-income countries, low and middle-income countries. So we don't have these big budgets, funded big cross-international projects covering all of this. So usually when we approach, it happens, some of them are, very helpful and provide us with these evidence tables of both whether systematic views or guidelines, and others will frankly request for an amount of money which, even if it is an unfunded project, not related to any commercial pharmaceutical, etc., etc. So I was wondering, is this normal practice, or going along with this open science and openness? If it's like an academic, non-commercial, educational initiative, maybe nobody has the right to ask for. I know this is a debate, but I'm just thinking loudly.
I mean, it's in an ideal world, I think everyone would share all the data, but I can see why there are some cases where people are hesitant to. But hopefully we can keep. I think it's improving, is what I will say, and I think it continues to improve, and hopefully even more so. And ongoing into the future, we're seeing more and more people share and collaborate their work. And I think some of the work you do, Yasser, and the Guidelines International Network do to promote sharing and collaboration is just so incredibly important in this space. So thank you for all you do promoting that.
Also, I meant to ask which organizations are you aware of are more open of sharing such evidence tables than the others? Are there any specific recommendations, or there is like none that come to your mind right now?
Yeah, we're at time, so I'll just have to very quickly say I work with a lot of Australian groups who are, I guess, individual consortiums sometimes who are willing to share their data. Some of the bigger groups, I'm not sure I should speak on their behalf. So we'll have to address this another time, but thank you, Yasser.
Okay. And thank you so much. Thank you.
And thank you everyone for coming along today. I hope you enjoyed the webinar. We certainly enjoyed interacting with you all and seeing you all in the chat. Thank you once again. Please do check out the GIN YouTube channel. This will be up there soon. And also, if you haven't heard of it already, there is a GIN conference in Glasgow later this year in September. I'd like to encourage you all to attend if you can. If you can't attend in person, it is a hybrid conference as well. So make sure you can register no matter where you are across the globe. So please do check that out. But thank you again. A huge thank you to Sue for taking time out of her day to present to us all, and to all of you for interacting. And we'll see you next time on the next ANZ GIN webinar. Thank you, everyone.